mentoring youth with type 1 diabetes. Before I introduce him, let me mention some housekeeping issues. We continue providing CME credits for our Tech Talks and our ID series presentations. So today is an ID series. We will distribute this information via email to those who registered for today's event. If you did not register prior to today's talk, you can still obtain CME code information from Deborah, and she will put her email address in the chat box. Some information about our upcoming events. So the next one is our Tech Talk, which will be on October 2nd. It's a Thursday. It will be at noon. And Dr. Zhugui Zhang, who is our one of our biostatisticians here at Krishna Care, will talk about metadata analysis. And that's something that, we have had several in the past months. So very interesting topic. October 28th, that will be a Tuesday, again, hosted by the Research Leadership Team meeting, will be Alison Karpin from University of Delaware, who will talk about food security and stigma. And then we have another tech talk in November, will be by Dr. Oday Dwikat from Krishna Care. Also, we'll talk about how AI and data science are being implemented at Krishna Care. So several really wonderful events. The next one being a tech talk by Zhugui Zhang about metadata analysis. So again, I'm really excited to welcome Dr. Enlow today. Dr. Enlow is research scientist in the Center for Healthcare Delivery Science at Nemours Children's Health, and also assistant professor of pediatrics at Thomas Jefferson University. He's also a pediatric psychologist in the Division of Behavioral Health at Nemours Children's Health. He obtained a PhD in psychology from West Virginia University and is currently funded by the Rich Cobre, which is led by Dr. Anne Kazak and Alder Frere, as a research project lead for his project, which is TechX, a peer mentorship program to increase equitable use of continuous glucose monitoring systems. He has been PI or co-I on several NIH-funded grants, as well as grants from AHRQ, grants from the ACCEL CTR, and from the Diabetes Research Foundation. He has already a long list of publications and has been invited to give talks regionally and nationally. So we are really honored to have Dr. Enlow today and very excited to hear his talk. So thank you so much, Paul, for being our speaker today.
Yes, thank you for the warm introduction, and it's great to see some familiar names and also some new names as well. So today I am going to be giving kind of a high-level overview of my program of research that I've been running since I started as faculty, and I've titled my talk, "You Got a Friend in Me," and I'm going to talk a lot about how I've been working to develop and now am testing a peer mentorship program for teens with type 1 diabetes. I do not have any financial conflicts of interest to declare, maybe one day, but not today. So I'm going to start by just giving a really quick crash course in type 1 diabetes for anyone who is not familiar with the condition. Then I'm going to turn and start by talking a lot about disparities in diabetes care and outcomes. I have gotten really interested in health equity kind of broadly, but type 1 diabetes is kind of my research home. So, this is where a lot of that interest started. Then I'll start talking a little bit about some of the formative studies that I've done that have led to my current pilot clinical trial of my family advisors had me rename it to Type 1 Together, which is our peer mentorship program. And there I'll be able to talk a little bit about some preliminary data and then talk about some future directions. And then I'm hoping to have 10-15 minutes at the end to be able to answer any questions that people might have. So let's start with the crash course in type 1 diabetes. Full disclosure, I'm not an endocrinologist by any means, so this is your psychologist education in type 1 diabetes. So type 1 diabetes is an autoimmune condition that affects insulin production in a patient's bodies, which then affects their ability to process sugar in their blood. So pretty much for most of us, when we eat food, we digest it, we extract glucose from it during the digestive process that goes into our bloodstream. And then insulin, we often describe it to patients as kind of like the key that unlocks their body's ability to use glucose to power their organs, muscles, and all of that great stuff. In your body, through insulin production and utilization of insulin, aims to kind of keep a normal level of sugar in the blood. But someone with type 1 diabetes, their immune system actually attacks and destroys the insulin-producing beta cells in their pancreas. And over time, what happens is they produce less and less and less insulin, and their blood sugars go higher and higher and higher until they are formally diagnosed with type 1 diabetes. So once a patient is diagnosed with type 1 diabetes, they and their family are then told that they need to follow a really complex medical regimen. They need to be pretty much acting as their pancreas every single minute of every single day. So they need to be doing things like checking their blood sugar throughout the day to see if they're high, low, if their blood sugar is in the recommended range. And then they need to use that information to make a treatment decision. Do they give themselves more insulin? Do they have a snack if their blood sugar is low? Things like that. They also need to count the carbohydrates that they're eating, and they use that information to calculate insulin boluses. They also, depending on the regimen that they're on, they might also have to give themselves insulin once a day, kind of a long-acting insulin that acts kind of like as a buffer or foundation that helps to keep their blood sugar in a more kind of normal level. And then on top of that, they have to stay physically active, they have to reduce stress, and they also just have to be a kid, right? So we want them to keep doing all of the things that normal kids are doing. The American Diabetes Association, a lot of other diabetes foundations are recommending that kids achieve a normal glycemic level, which they define as having a hemoglobin A1C, which is the most commonly used lab test to measure glycemic levels of about 7% or less. So this is really hard for our patients. Even our patients who are really, really motivated, just doing all of these things is difficult. You forget, you might make a math error, things like that. And then you add on, as soon as you start going through puberty and all of that, the hormones that the other hormones going through your body just make it a lot harder for patients to effectively manage their condition. And then if any of you guys can remember what it's like being a teenager, when you start doing things on your own, you're going to mess up too. So this is really difficult. So very few of our patients actually achieve those recommended glycemic levels. Most recent estimates put it about like 1 in 5 to 1 in 3 patients are achieving those recommended glycemic levels. So most patients we see have high levels. And if that isn't addressed, they can be at risk for complications in the short or the long term. So fortunately, there are a lot of diabetes technologies that are out there to help patients better manage their condition. When I started at Nemours back in 2016, insulin pumps had been around for a while, but continuous glucose monitors, which I'm really interested in, had really just kind of come out into the field, and they were becoming more readily available to patients. And pretty much what a continuous glucose monitor does is it allows patients to see what their blood sugar is without performing finger sticks. So all of us probably have a cell phone. And for a patient with type 1 diabetes that's using a continuous glucose monitor, they put it on the back of their arm or on their abdomen or somewhere. And then their numbers are actually just displayed right there on their phone. So they can look at their phone. If you ever met a kid, they all have their phones on them. They can see what their blood sugar is, and then they can make a treatment decision. Continuous glucose monitors also do things like giving people alarms if their blood sugar is high or low, or if it's going in a bad direction, right? If their blood sugar is in the normal range, but the algorithm picks up that, hey, your blood sugar is increasing and we predict you're going to be high in the next half hour, then the patient can do something to actually try and prevent that high blood sugar. And last but not least, patients can see their blood sugar trends over the course of weeks and months. So they can see maybe where problem areas lie, and they can make more precise, have more like precise conversations with their diabetes care team about tweaks to their self-management tasks. In addition to that, patients can have an insulin pump. So rather than injecting insulin multiple times per day, they wear a little pump on their belt or just attached to them that will give insulin kind of more fine-tuned doses throughout the day. Patients who use insulin pumps, not only do they have better mental health outcomes, their health is really improved as well. Another thing that I think is really cool, and I could geek out about it for hours, is what are called automated insulin delivery systems, or AIDs. And pretty much what they do is they let the CGM and the insulin pump talk to each other, and the insulin pump will change how much insulin it is giving based on current blood glucose levels. So it's really, really cool because patients can actually put these devices on, and besides telling the pumps like when they're eating, um, the pump is kind of doing everything in between. So it's working really hard to keep patients in that recommended glucose levels. So not surprisingly, if you get a patient on one of these automated insulin delivery systems, that is really, really good with regards to their health outcomes. And it also has some promising stuff for their mental health as well. So I'm really interested in the teenage years, mainly because teenagers are fun to work with, but they also tend to struggle the most with type 1 diabetes. So this is, it's a little bit of a busy graphic, but it is A1C trajectories across 3 national registries. The leftmost is the Australian registry, the middle is a German registry, and the one to the right is a registry from the United States. So it shows average A1Cs based on year, how old the patient is. And while you can see different trajectories and things like that, one of the things that we see across every single registry is that once we hit those preteen to teen years, we see that there are 2 groups of patients that represent, at least 20%, if not more, that have elevated glycemic levels. They kind of shoot up and they go up and they stay up, and even until they're, becoming adults. These patients need a lot of support. The typical approaches don't tend to work. And it's something that, there's additional focus needed for this population. In addition to that, we see a lot of issues with health equity in diabetes care and outcomes. So all of the stuff I just talked about, like insulin pumps, continuous glucose monitors, things like that, they are really great. And they've been around for a while. But when we look at we look at kind of who is struggling the most with managing their diabetes, for decades, we have seen that Black youth and Latino youth tend to have higher A1Cs compared to white youth. This is a study that was published back in 2018 that kind of showed that Black youth and Latino youth were more likely to be in that kind of grayish blackish line, which indicates like a high kind of elevated glycemic trajectory. We can look at other outcomes too. We see disparities in when it comes to rates of DKA and hospital admissions and ED visits. We see worse mental health outcomes, and we see lower rates of insulin pump and CGM use. And this is kind of where I entered the stage back in 2016 and got really interested, because I was working with patients clinically, so I was doing psychotherapy with patients both in clinic and outside of clinic to work on barriers to adherence. And while there are a lot of mental health barriers, right? So kids get burnt out, they get depressed, and that can affect their engagement with their care. I also saw that there were things that were outside of this, right? So a lot of the patients who were struggling the most with their diabetes didn't have access to CGM or pump, or they had access to these devices, but they didn't use them well. A lot of my patients who were wearing CGM were using them kind of not retroactively. They were just kind of responding to alarms, but they weren't using them to like prevent high blood sugars or low blood sugars. Or they'd wear them inconsistently. They'd wear them for a little bit and they'd say, hey, all my CGM does is beep while I'm in school, and I don't like it because it singles me out. I don't want to wear this thing anymore. So I started becoming interested in what can we do to help families get the most out of their diabetes technologies. So I'm going to shift and start talking a little bit more about my program of research. It's been guided by the NIH STAGE model for behavioral developing and testing behavioral interventions. Most of the slides that I covered today are going to focus on stage 1, which is just generating and refining the treatment, and stage 2, which is those kind of initial pilot studies. This can kind of map onto the orbit model if you're more familiar with that as well. The NIH STAGE model just kind of also includes things around like dissemination, implementation, and kind of talks about efficacy in 2 different ways. So my formative studies were my formative studies really focused on hypothesis generating and then trying to better understand what could we do to address barriers. So I started by wanting to know what are the barriers that families face when they're trying to get on or start using or continue using insulin pumps and CGMs. So we did the study, we started it, I believe, in like January of 2020. And so this was a little bit affected by the pandemic. But a lot of what we learned is still pretty generalizable. So we interviewed youth of color with type 1 diabetes, their caregivers, and some of our providers here at Nemours. So for the teens and the caregivers, we asked them about their experience in getting on and using these devices. Healthcare providers, we also just asked kind of what their perspectives were about the barriers that families faced either when initiating or trying to keep up with using these devices. Um, After these interviews, we coded it and then distilled this information into themes. I'm happy to talk a little bit more about the qualitative process if people are interested. But I feel like the results are usually kind of what's a little bit more interesting. So we had grounded our analysis in the social ecological model where we kind of recognize that there are barriers at different levels. There are things ranging from what families think about devices all the way to things like how much a device costs, the insurance process, things like that. So we identified barriers and facilitators at different areas. Some of these things could act as a barrier or a facilitator depending on kind of the how it's presented. Some of the stuff isn't surprising, right? So what families think about the different devices influences whether they want to use it. Family dynamics, so whether the teens and the parents are getting along or they're fighting all the time can affect their ability to start or continue using devices. We also saw things at the provider level. So kind of back in 2016, there was a lot of provider decision making around who might be a good or not good candidate for technologies. And so they might have some ideas about, when they want to prescribe it, who they want to prescribe it to, and things like that. Patient education, at that point, it was mostly done in person. So that was a pretty big barrier to some of our families who had to travel a good distance. Unfortunately, now we do a mixture of in person and can do some telehealth too. But outside of the hospital, we saw a lot of things that could make it harder or easier for families to get on technology. So the cost of these devices is high. While insurance coverage nowadays is much better, if you have a insurance that has a high deductible or high out-of-pocket expenses, that can still be a huge barrier to families. I've talked with families where they have to make a decision about whether they wanted a CGM or an insulin pump because they weren't going to be able to afford both. The approval processes now are fortunately a little bit smoother, but families can still run into issues, right? So they can get denials, and families who are less familiar with the healthcare system may not know what to do about appealing a denial or something like that. Interestingly, though, we also heard from a lot of families about how the diabetes community and device companies were really, really helpful. So a lot of families learned about new technologies or even how to advocate for them, for their child, from families they met, whether that was through schools, like diabetes walks, things like that. They also learned a lot from device companies. So, seeing a commercial about a CGM, or even just seeing like the videos that are hosted online. A lot of these device companies have videos like how to use their devices or just advertising, and they would see that and get really interested and motivated. So we had an idea of what the barriers were, and now we wanted to come up with solutions. So I'm not a person with type 1 diabetes. I also don't represent any of the sociodemographic groups who carry a disproportionate amount of disease burden. So we assembled an advisory board that consisted of youth of colors, caregivers, a physician, and a nurse practitioner. We presented them with results from a previous study, and we said, okay, what do you think we can do about this? And over the course of a number of meetings, we came up with a number of different solutions. So I'm not going to present an exhaustive list of all of our strategies because that would take a while. But here are just a couple of examples of the strategies and how they were tailored to the specific barriers, right? So if we think of the health system, a lot of families would hesitate to reach out about an insurance denial because they weren't sure who the right person was. They didn't want to bother the healthcare provider because they felt that they were busy, and they didn't necessarily know about our social worker and things like that. So designating a point person could help with these insurance questions. Some of our families had a lot of things they wanted to discuss, but then they get in with their provider, they want to talk about, starting on a CGM, or they have questions about their insulin pump, but maybe their A1C comes back and it's not what they expected. And so while they wanted to talk about these things, they forgot in the heat of the moment, and then they might have to wait a few more months before they can talk with their provider again. And a lot of our families wanted peer mentoring to learn about different technologies and how to use them. So we came up with a number of different solutions, and then we wanted to get another group of people to say, like, okay, do these seem like good ideas or not? So we created a video where we described the barriers and the potential solutions, and then we showed this to families, the demographics of which are like the sample is described a little bit up there, as well as some healthcare providers. And we asked them, what do you think? Do you think that this makes sense? Do you think that we've hit all the barriers? Things that might have changed a little bit now. Is there anything new that we should be aware of as well? So again, I'm not going to go through the exhaustive list, but we came up with a lot of different strategies for different barriers. So for example, when families had negative perceptions of diabetes technology, maybe they didn't trust their CGM or didn't trust an insulin pump. Some of our teens thought that, a peer mentor would be great because you get to meet with someone who knows about this device and they can teach you lots of things. They liked, being able to be connected with mental health providers to address family disagreements about technologies. Lots of different kind of strategies that for different barriers, but we started noticing some themes, right? We started noticing that a lot of families liked the idea of a peer mentor, but they felt like that wasn't going to solve everything, right? So we've identified barriers at multiple levels of the social ecology. We identified potential solutions to address these barriers. The preferred solutions varied based on the barrier. So for example, families who were experiencing an insurance challenge didn't necessarily want to go to a peer mentor because they felt like that person's not going to be able to help me through appealing a denial or something like that. But if they knew the person to talk to at Nemours, they would be more likely to do that. The preferred solutions really focused on peer mentoring, making it easier for families to access education, and then making it easier for them to communicate with their medical team when they needed it. So I had a research question, we had some identified problems, some potential solutions, and we're now at a point where, hey, we need to actually test this out and see if it does anything. So I was fortunate enough to receive a funding from the REACH COBRI for a targeted project, which would allow me to develop and then pilot test our intervention, which we've named Type 1 Together. So here are the aims for my pilot. The first aim was just refining Type 1 Together. So we had ideas, we kind of thought we knew what we wanted to do, but we had to, we developed like a mentor manual. How are we going to train our mentors? What are they going to be doing in those meetings? Things like that. Our process for selecting and training them, all of that fun stuff. We wanted to hire and train a community health worker. So we had to think through that process and develop an SOP for them as well. And then once all of those pieces were in place, we wanted to evaluate the acceptability, feasibility, and efficacy of Type 1 Together. So our goal was to have at least 80% of families rating Type 1 Together as acceptable. At least 80% of families will meet at least 5 times with their peer mentor. And then that families who participate in Type 1 Together will report improved perceptions of CGM, use their devices more consistently, and have reductions in A1C. A third aim, which was a little bit of a reach goal to see, but we wanted to see if we could measure whether or not Type 1 Together reduced disparities in CGM use or glycemic levels. So we're still enrolling, but we recruited 10 mentors that were 17 to 21 years old, diagnosed for at least a year, doing well with managing their diabetes, meaning their A1C was not too high and they didn't have any recent kind of ED visits or hospital admissions. And then we did a screening where myself and one of our family advisors met with them and did kind of like a 30-minute interview and chat to get a chance to make sure that they were a good fit. that ended up actually being fairly important because we did have a couple of people who were interested in being mentors, but it seemed like maybe it was the parents driving the ship. And once we started talking with the teens, it was clear that they were not as interested. And so, being a mentor was not maybe the right role for them. We also were obviously recruiting mentees who are 12 to 17 years old, diagnosed for at least 6 months. We're using CGM inconsistently, which we define as less than 80% of the time. That definition is clinically relevant. So a lot of the data on CGM wear time shows that you need to be wearing it at least 80% of the time to yield some reduction in your A1C. Or they had a most recent A1C that was elevated. So we do have some patients who put their CGM on, they wear it, but they don't do anything with it, right? Say that you can mute alarms, you can turn them off, you can actually set alarm thresholds that are just not very clinically useful. So we do have some patients who are wearing their devices, but still have very high A1C, so they're not effectively utilizing it. We also wanted our families to speak English and have a caregiver that was willing to participate. So Type 1 Together, it combines peer mentorship. So when families meet with our peer mentors, they can get informational support so they can learn about new things. They can learn about how to get the most out of their devices. I'll talk a little bit more about that later. They can get emotional support. So, having diabetes is hard. Sometimes you don't need someone to tell you what to do differently, but you just need someone to kind of support you as you're working through stuff. And then lastly is appraisal support. So appraisal support is kind of related to emotional support, but it's helping families focus on kind of not get bogged down in maybe just their challenges. So we have found that with a lot of our mentoring sessions that the young adults do a really great job of kind of lifting up the teens and helping them focus on things that are going well, in addition to things that maybe they need to continue to work on. Technology supports were a number of different things. It included things like automated outreach via the Nemours app, or kind of our version of MyChart, which is just a way to facilitate some communication with families before clinic visits. We also built into our version of MyChart videos and handouts on using diabetes technologies, because a lot of our families said it would be great if I had this information, but I don't know where to look. So we put it all in one centralized location. And then we have a community health worker who meets with our families monthly to try and help them with other things. So this is our person who's going to help field questions related to insurance, help getting them connected with different people. They might be helping with social determinants of health as well. We've had some families who, because of a job change, all of a sudden couldn't afford their kids' copays, right? And so our community health worker could either point them towards resources or connect them with someone within Nemours who could help address that. And our hope is that with these two things combined, families would feel that CGM was a better use for them and their child, use CGM more consistently, would see improvements in A1C. And then the last outcome was actually a recommendation from my family advisors. They said, if I met with a mentor, I feel like I would just feel less stressed out about having diabetes. So you should measure something about that. So we threw in a measure of diabetes distress. That is pretty much the psychological distress that comes from just having and managing type 1 diabetes. We can see it both in teens as well as in parents. And diabetes distress is highly related to things like A1C. So people who are more distressed tend to have higher levels of A1C and are therefore at greater risk for health complications. So reducing diabetes distress is very clinically meaningful amongst our population. Kind of my methodologists out there, here's kind of a overview of our design. So families were enrolled and then randomized 1-to-1 to either Type 1 Together or a standard care control group. Families randomized to our Type 1 Together. We're in the intervention phase for 6 months, and then we're doing a 6-month post-treatment follow-up. They were supposed to meet about monthly with their mentor, as well as monthly with their community health worker, and then would have access to the diabetes app throughout the intervention phase. Partway through the intervention, they should have 2 clinic visits, and the community health worker was there to help with that visit prep or proactively address issues related to attending the clinic, like that copay example I mentioned. This data is a little bit dated. I didn't do all of the math, so I apologize. We've screened about 400-ish families. We've now enrolled about 33. We have one person who is literally just freshly enrolled and they've not yet been randomized. That's why the numbers don't totally add up. But we have a pretty good enrollment rate regarding with a harder to reach clinical population. And we have a number of people who are still eligible, and we're still trying to work to enroll. Okay, so I'm going to show some preliminary data that really focus on the hypotheses related to AIM-2. While I'm very interested in AIM-3, we just don't have enough data at this point to, do a rigorous evaluation of those questions. So I'm just going to focus on hypotheses 2A, B, and C. So we measured acceptability with the intervention using the acceptability of intervention measure. And then we also just asked teens and parents how satisfied they were, 1 to 5, with their mentor. Higher ratings equaling greater satisfaction. Our goal is to get as many people as possible to a rating of 4 or 5. So the program acceptability, which was assessed using the acceptability of intervention measure, is high. We're hitting or exceeding that goal of 80% of our families at 4 or greater. Also, most of our people are very satisfied with their mentors. We had one teen who kind of flip-flopped. And so that kind of brings the teen rating down a little bit, but generally people really like their mentors and have been very satisfied with that. We also do qualitative interviews as families leave the intervention. The things that they really like about the intervention is they just like connecting with families. They really like goal setting. So during that initial meeting, most of our mentors ask families, well, what do you want to work on? We're going to be working together for 6 months. What would you like to improve? And they've shared that that's actually been very helpful in kind of organizing their thinking and getting them a little bit more motivated. They really like getting advice on managing diabetes, and they really like the virtual setup. So all of our mentoring is done via study-specific Zoom accounts. So families really like that. It's been very flexible. It's great. Things I don't like is that scheduling is a pain, which I'm sure everyone here can relate to. So that's been something that people don't like. A lot of people also want to meet longer with their mentors. So I feel like that's a good thing, right? They like their mentors and they want to meet more. It's better than kind of the opposite, which is there are too many meetings. And then one piece of feedback we received from a mentor who ended up kind of graduating and then leaving the program is that they would have appreciated some guided questions related to their meetings. Some of our families, they joined that first meeting and they have a million things they want to discuss. Some of our families are a little bit slower to warm, and so some guided questions for meetings could kind of help grease the wheels with someone who's a little bit slower to warm. And then the other suggestion is just more meetings with the mentor. When we look at how many people are, or sorry, how often people are meeting, it's about 4.5, right? So a lot of people hit 4 meetings over 6 months, which is pretty good, right? That means they only go 2 months in that phase without meeting. Some families meet more. I have one family who's met like 8 times, which is cool. That's really great. About 60% of our families currently are meeting that goal of 5 times. We're trying to get more people to 5, but we're seeing that people tend to like hit about 4, and then that's kind of all that they can do in the 6-month time frame. Everything is virtual, mostly Zoom. One family had a hard time using Zoom, and so they asked their mentor if they could switch to FaceTime. We had written that into our IRB protocol that we'd let them do that at the mentor's discretion. They did it. It seems like it worked out just well, and it didn't seem like there was any inappropriate use of FaceTime, like the mentee calling the family at like weird hours or anything like that. The meetings last, some of them are like 15 minutes. Sometimes as the mentoring program goes on, things have gotten better, which is great, and then they just don't need to meet as long. But the meetings have also lasted as long as an hour, and then no emergencies have come up during, or like ethical issues have come up during our mentoring sessions. So when our mentors finish a mentoring session, they fill out a short survey where we ask them, what'd you guys talk about, or who'd you meet with, what'd you talk about, and did you have any problems? So far, no problems that haven't been like technical issues. When we asked them what they talk about, there was a lot of different things. So most families do talk about CGM, which they're supposed to be doing, right? We're trying to encourage CGM use, help families get through those issues. But a lot of other things are coming up too. A lot of our teens and families are asking about things like peers. Maybe how do I talk to my friends about the fact that I have type 1 diabetes and let them know what to do if there's an emergency? How do I manage diabetes effectively in school? We've had some families share pretty horrendous experiences where their child has been told a teacher tried to take away a kid's insulin pump because they thought it was a toy, like a Game Boy or something like that. And the kid had to, in the front of his classmates, be like, no, 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 like I need this thing. And so there's been a lot of discussion around that. Family communication has come up quite a bit. Mental health issues, some things around self-management tasks like giving insulin, counting carbs, checking blood sugars. Not represented here. Families can also select an other tab or another option and then write in a bunch of things. The things that have come up most often in that open-ended response section are things like how do I play sports with diabetes and driving, which makes sense. We are focusing on teenagers, and that's actually can sometimes be a very big issue for some of our kids because either they want to drive, but their parents don't want them to, or maybe they're being irresponsible with their diabetes management, and we need to make some changes before they'd be safe to drive. Okay, here's what I'm most excited about. Does it work? Maybe. It actually is looking kind of promising. So we have post-treatment data from the first 20 participants. That's 6-month data. We are seeing small to medium improvements in health variables, medium effects on psychosocial variables, and it seems like teens who are participating in type 1 together may be experiencing lower A1Cs. I did delete the thing on time and range. Sorry, if people are interested, I can talk about that. Are more likely to use CGM consistently and have some decreases in diabetes distress. Here are my graphs for people who like a nice graph. So here's our blue line is always going to represent our treatment group, and our orange line represents our control group. So we can see at when our families enter the study, their average A1Cs are about the same, but our treatment group has a very nice decline over time compared to our control group, which is relatively stable. Just as a caveat, we did have a couple of families who seemed like they really benefited in our type 1 together group. And so that's kind of why that average is brought down so low. I think as we get closer to our full sample, that number will probably creep up a little bit more. So that difference, well, it looks really pretty right now. I don't know if it will hold once we have all 30-odd families in there. Wear time is really great, and it's going up. So amongst our treatment group, we see that families, when they enter the study, we see a lower, for some reason, just due to randomization, people randomized to our treatment group had lower wear time on average, but by the end of our intervention, it was close to 100%. Our usual care group does have a little bit of an increase, but it's not as dramatic as our control group, or sorry, treatment group. I'm also particularly interested in diabetes distress. Again, this was not my idea. This was actually an idea from my family advisors. So, want to give them credit for their ingenuity. So this is a measure of adolescent diabetes distress. Higher is worse. The cutoff score, so clinically significant diabetes distress, is a score of 44 or higher on the teen scale and 54 or higher on the parent scale, which I'll show on the next slide. And so when people are coming into the study, their average A1C, or sorry, average diabetes distress is close to that clinically significant point, if not above it. Our treatment group goes down over time, and by the 6-month time point, the average is well below the clinically significant cutoff, where our control group actually seems to be kind of more or less right where they started, which is also very close to that, or right at that clinically significant cutoff. When we look at parents, we see a similar pattern, less dramatic among our parents, but we do see a decline. And this average at the end for our treatment group is just below the clinically significant cutoff, where the treatment group, or sorry, control group kind of remains, their diabetes distress levels remain clinically elevated. So I'll talk a little bit about future directions. I can also talk about just like lessons learned and kind of what the experience has been like. This has been one of my favorite projects I think I've ever done, but it's a lot of work. And it's been cool to see it grow and see it actually get put into action. It's been really cool to work so closely with this community. It's really cool because as I've been talking about future directions, the people I've been working with on this project, they want to keep doing it. So it's not only is it some stakeholder engagement at the forefront, but it looks like these partnerships are likely to continue going forward. The pilot data look promising. So let's do a multi-site RCT. We've learned a lot, and we think what we've learned can help us make this intervention more acceptable and feasible. And it's going to help us kind of modify some of our training as well. I'm currently writing an R01 that I'm going to submit to NIDDK in October. NIH funding is in flux at the moment, so we're also looking at non-NIH funding as well. Breakthrough T1D is a diabetes foundation that funds a lot of larger research projects, and this might kind of be right up their alley. It's formerly the Juvenile Diabetes Research Foundation, or JDRF. People may be more familiar with that, but they rebranded recently. I also submitted a Spanish version, a proposal to the National Institute of Minority Health and Health Disparities for an R21 to adapt our current program for Spanish-speaking families. So Spanish-speaking families aren't included in our current pilot, but when you look at the literature, families who have less English language proficiency tend to have higher A1Cs and are less likely to there are some disparities in care. Really cool thing is that it was scored at the 15th percentile, which is within the fundable range for NIMHD. There's lots of changes at NIH, so it's been a little bit of a roller coaster of emotions going through all that. But council meets in October, and we're crossing our fingers that we might get some funding. One of the interesting parts of this too is this was I had a Latina family, a mom and a daughter, who joined on to kind of be consultants on my project. And from day one, the first thing she said is, you need to do this for Spanish-speaking families because this mother is bilingual, and she shared a lot about her experience being diagnosed and kind of the challenges because most of her family does not have as lower English language proficiency. And she said, it was really, really difficult for me, but it would have been amazing if I and my family could have had a mentor family to work with in that new diagnosis phase. So a lot of credit to her idea and her advocacy that we are kind of continuing to say, we should do this, we should do this, we should do this, is the reason that we put together this proposal and kind of why it was scored so well. But we have some ideas around things like cultural and linguistic adaptations. So we can see some differences in like acculturation, depending on if kids were born here or in a different country. We also see clinically a lot of differences in parent and teen preferences with regards to language. A lot of our teens want to do their visits in English. The parents want to do them in Spanish, or maybe can only do them in Spanish. And so that can create some interesting dynamics when it comes to mentoring, because should we be doing those mentoring sessions in English? Should we be doing them in Spanish? Should we be doing them in kind of a mixture, and kind of how to address all of that fun stuff? So as promised, I was going to try and save 10 to 15 minutes for questions, and it looks like I did that. So thank you for being a listener and a friend, and I'm happy to answer any questions that people have.
Thank you so much, Paul. This is fascinating, really fascinating. There is a comment from Wendy in the chat that you may want to look at. And thank you so much, Wendy, for your message. Any questions from the audience? All right. Well, I have questions. When you select your mentors, do you match the mentors with a mentee? Is there a matching process, and what type of criteria do you use?
Yeah, what a great question. The hours that we've spent talking about this, it was very contentious. We thought, like, do we match them? And how do we match them? And what we decided actually was to not do that, right? So we felt if we match someone, or if we ask them their preferences and match them with someone, and we don't necessarily know what family's most important or least important characteristic is, and so we worried if that they weren't that perfect fit. is this going to start the mentoring relationship off on a bad foot? So instead, what we do is we have a pool of available mentors. So our mentors are not allowed to mentor more than 3 people at a time. Most people hit 2 and then they say like, I'm done. Not they're done permanently, but like I can't take on any more, which fair. That's a lot of work. But what we do is when someone enrolls in our program and is randomized to the treatment group, we then say, okay, here are the available mentors. You can pick from one of them. Let us
Oh,
know
wow.
within a week. And so that way families are self-selecting. Mentors have a little bio, which has a picture of them and their parents, usually doing something fun. It talks about, how long they've been diagnosed, what treatment regimen they use. It also just includes some like fun facts about them that aren't diabetes related because our teen said, I don't necessarily care as much about their diabetes characteristics. I care more about this person as a potential person. So it, might talk about like, oh, I play sports or I've always wanted to go, you know, to Europe when I graduate high school or whatever it might be. And so that's how families have selected their mentors. And we haven't actually had any feedback that that's a bad process, and it kind of sidesteps the matching issue.
That's really interesting.
We have had we actually had to recruit some additional female mentors because uh, we had a number of female participants who wanted female mentors, but we've not had the other way around. So that's interesting. I don't know what to make of it, but yeah, that's been an interesting thing.
That's really interesting. I guess I don't know whether you'll have enough power to do that, but an analysis would be also to see whether, according to gender, whether how it works, whether the outcomes are better or different, not
I
better, but
know.
different from
Yeah,
according to
it'll
the mentor gender.
it'll be interesting. Sorry, like as a tangent, as a psychologist, right? When I'm working with patients, sometimes that I've definitely worked with patients who they needed a same-sex therapist, right? And that's been really important. I've also had times where we're able to overcome that, right, and still have a really successful like therapeutic relationship. But I've also had some times where it's very clear early on that like this person just doesn't feel comfortable with me as a man, and I need to get them to a different therapist. So I'm wondering, yeah, to your point, if we might see something similar.
Any other questions? Oh, I think there is a question from Kim in the chat
Yes.
related to implementation. Do you have
Yes.
plans to incorporate implementation science methods in your future research in this area?
It's like I feel like you read my like aims page. Yes, for my R01, so our third aim is actually related to implementation, mainly because so we're using the PRISM framework to and sorry, I'm not an implementation science expert. I have a co-I who is. So if I use the wrong terminology, I apologize in advance. But we're using the PRISM framework to better understand kind of what are the potential contextual barriers that might affect implementation. I'm particularly sensitive to the fact that peer mentoring is not a billable service, right? And that can be really important if we are looking at sustainability of a program. There are also, anecdotally, when we've tried families have asked to be matched up with a mentor. Before we did all of this, there were a lot of HIPAA and barriers and things like that to get through. So thinking through some of those kind of legal logistical challenges might be important as well. So we're hoping that the PRISM framework, we're using kind of like a mixed methods approach to get at that, would allow us to better understand what are not necessarily just the barriers, but what are the potential solutions. Because I'd love for, if this is successful at a multi-site clinical trial, for us to be able to continue it on in the future.
Any other questions? Well, I have another question. Maybe I misunderstood, but the mentors, do they always talk to the teen and the family together, or do they have opportunities to talk, in person, just with the teen, just with the
Yes,
adolescent?
this is also hours of debate amongst my team about what to do with this one. So right now we have the parent and the teen meet, or sorry, the families all meet together. And this was done out of concern that What if they're who's going to be supervising, right? Kind of like, what if people go off and give bad recommendations, or what if the teen says like, says something inappropriate or whatever. So right now people are meeting together. We use this as kind of a more conservative, kind of protective way to protect our participants. So far, things have gone well. And if anything, our participants have wanted to meet separately. So the teens go and talk, or like the patients go and talk, and the caregivers go and talk. So for our R01, we're planning to do that and transcribe the meetings via Zoom as like a QA type process. We have had some parents where they set the teen and the young adult up and they stay in the same room, but they like go do other stuff. So the teen and the kid can kind of talk, but the parent can just eavesdrop and listen in. And that also seems like it's actually gone fairly well. Usually the parents will go like, they're folding laundry. They're still there, they're still listening, but they're just not as physically present or in the camera's view. And that's actually been really, really beneficial for some of our kids who are slower to warm. As a side note, all of my family advisors have also been yelling at me from day one that I need to let them meet separately. And so it's been a little bit of a
Oh,
push and
really?
pull of like, what's the regulatory, I'd explain to them like what an IRB is and how we wrote the protocol up. And, if we change it, we need some rationale as to why we're changing it, and kind of that this is the pilot data collection process and we will change it going forward, which seemed to kind of satisfy a lot of those opinions.
Yeah, that's fascinating. So many questions, right? That can be
Yeah.
that are raised by this method, and I would imagine that when we talk about mentor-mentee relationship, you really think about a long-term relationship, right?
Yep.
Is it something that is it the teens, the mentees express that they would be interested into, keeping a mentor and working long term with a mentor?
Some people, right? I think it's family to family basis. We've had some families that seem like they really hit it off and they would love to kind of continue it. I think the part we've been thinking through is, well, what do you do when a mentor is done being a mentor, right? How do you let them bow out, but also not leave that person high and dry? I've thought it would be interesting to have like, I call them like alumni meetings, if that makes sense. So rather than the mentors and the mentees necessarily meeting separately, take people who have completed the program and then invite them to, a quarterly, you know, virtual program or something like that. That could be run by a couple mentors and maybe like a social worker, psychology training, something like that. And that way people who want that ongoing mentorship can get it. But also mentors don't feel so beholden to one family that they can't bow out once they're done. That's just a half-baked idea. If anyone has a good idea of like how to test that or run it, let me know. It's just swimming in my brain at the moment.
Sounds like a great idea. All right. Any other questions? All right. Well, thank you so much, Paul. This was a fascinating presentation. And let us know when you get your R1 or